Hello, everyone, and welcome back to the deep dive. Today, we are pivoting. Usually, we take a broad topic, history, tech, whatever, and drill down for general curiosity.
Yeah.
But today is tactical.
Right.
This one is designed for a very specific listener. You are probably tired, you're probably overcaffeinated, and you are definitely staring down the barrel of a major exam, whether that's the FRCS Urol, the European boards, or the American AUA boards.
The high-stakes listener. I know that feeling well. The stack of books, the endless PDFs, the fear that you're going to forget a critical cutoff value right when the examiner looks at you over their glasses.
Exactly. And on the desk today, we have the weapon of choice for those exams. The 2025 EAU Guidelines on Sexual and Reproductive Health. It is a massive document.
Monster.
265 pages, thousands of references. It's the kind of PDF that, crashes your browser if you scroll too fast.
It is.
Our mission today is to stop you from having to read the whole thing at 2 in the morning. We are going to distill this into the absolute high-yield exam favorite nuggets.
And let's be clear about what this document represents. It's a beast, yes, but it's also the Bible. I mean, if you are sitting across from an examiner in an oral board and they ask you about managing a priapism or working up infertility, you don't give your opinion.
Right.
You don't give what you saw your attending do last week. You give the EAU algorithm. That is your safe harbor.
So we're going to act as that filter. We're covering hypogonadism, sexual dysfunction, the absolute emergency of priapism, penile abnormalities, and male infertility.
All the greatest hits.
But before we get into the weeds, I want to talk about the philosophy here. The guidelines open with a statement that feels a bit grandiose. They say this isn't just about plumbing.
It isn't. And this is a critical mindset shift for the exam and for your future practice. Historically, urologists were just plumbers. If it leaks, plug it. If it's blocked, ream it out.
Sure.
But these guidelines frame sexual and reproductive health as a window into general male survival.
Survival. That seems dramatic for erectile dysfunction.
It sounds dramatic, but look at the data. I mean, it's really solid. Erectile dysfunction isn't just a nuisance, it's a vascular event.
Okay.
Hypogonadism isn't just about libido. It's about metabolic syndrome, bone density, and cardiovascular risk. If you treat these as isolated symptoms, you miss the boat entirely. The guidelines are shouting at us. Treat the man, not just the penis.
Meaning, if a 45-year-old comes in with EB and you just throw Cialis at him without checking his lipids or his glucose, you have failed.
You have absolutely failed the patient, and you will definitely fail the exam. The examiner is looking for that holistic safety check. They want to know that you understand the systemic implications.
Okay, point taken. We are general physicians first, urologists second. Let's dive into section 1. The foundation. Male hypogonadism.
The most controversial topic in men's health and arguably the most mismanaged.
It feels simple on the surface, low T, but the definitions here are surprisingly slippery. I feel like every year the societies fight over the cutoff numbers. What does a 2025 text say?
They've doubled down on the definition. Hypogonadism is a clinical syndrome. That is the phrase you must memorize.
Clinical syndrome.
It is a constellation of clinical symptoms accompanied by biochemical evidence.
So let's be precise. You cannot diagnose it with a lab slip alone.
No. And you cannot diagnose it with symptoms alone. If a guy is tired, fat, and has no libido, but his testosterone is, say, 20 nanomoles per liter, he does not have hypogonadism.
Right.
He has depression or sleep apnea or a bad job. Conversely, if he feels great, is building muscle, has a great sex life, but his T comes back at 9, you do not treat him.
Treat the patient, not the number.
Precisely. Now, for the exam, you need to navigate the classification. This is where residents get tangled up in the hyper and hypo terminology. It sounds like word salad if you don't have the physiology locked down.
Primary versus secondary. Give us the heuristic to keep them straight when the pressure is on.
Follow the anatomy. It's the easiest way. Primary hypogonadism is a problem in the testicle. The factory is broken.
Okay, the factory.
And because the factory isn't making testosterone, the pituitary screams at it to work harder. It pumps out LH, luteinizing hormone, and FSH. So biochemically, primary is low T, high LH, hypergonadotropic.
And the classic case study here, the one you'll see in a vignette.
Klinefelter syndrome. 47,000 XXY. You have to know the phenotype. Tall stature, gynecomastia, and critically small, firm tests.
Why? Firm. I feel like that's a detail they'd ask.
Fibrosis. The seminiferous tubules are hyalinized. It's all scar tissue. Contrast that with secondary hypogonadism.
It's just a brain problem.
Right. The testicles are fine. They're just waiting for orders. The pituitary or hypothalamus is asleep at the wheel. So you have low T, but low or inappropriately normal, LH and FSH. The signal is missing. This is hypogonadotropic.
This is the prolactinoma patient.
Exactly. Or the Kalman syndrome patient, which is the classic medical student exam question. The patient with delayed puberty and anosmia, they can't smell.
Right.
If you see can't smell in the vignette, it's Kalman until proven otherwise. It's a dead giveaway.
Now, the guidelines have a whole section on functional hypogonadism. This feels like the messy middle. The guy who isn't born with a genetic defect and doesn't have a brain tumor, but still has low T.
This is 90% of what you see in the clinic. The overweight 50-year-old diabetic. The guidelines are very, very firm here. This is usually not an organic failure of the HPG axis. This is the body suppressing the axis to survive.
Explain the mechanism there. Why does being overweight crush your testosterone?
Well, there are several pathways. First, visceral fat is metabolically active. It contains aromatase, which converts testosterone into estradiol. High estradiol feeds back to the pituitary and shuts down LH production.
Aromatization?
Right. And second, the inflammatory cytokines from metabolic syndrome, they directly suppress the hypothalamus. It's a double whammy.
So if you give this guy testosterone, are you fixing him?
You're masking the problem. You're painting over rust. The strong recommendation in 2025 is treat the underlying cause first. Weight loss, lifestyle, optimization of diabetes. If you get the BMI down, the P often bounces back on its own.
But practically speaking, patients hate that advice. They want the shot.
Of course they do. It's the easy answer. But for the exam, you must prioritize the lifestyle intervention for functional hypogonadism. That is the correct answer.
Okay, let's talk about the workup. The examiners love to catch you on the logistics of the blood draw. You can't just draw it at 4 p.m. after a steak lunch.
No, you can't. It's mandatory fasting and mandatory morning.
Yeah.
Specifically between 07.00 and 11.0 hours.
Why the strict window?
Circadian rhythm. Testosterone follows a diurnal curve. It peaks in the morning and crashes in the afternoon. In a young man, the difference can be 30 to 40%.
Wow.
So if you test at 3 p.m., you were diagnosing a false positive. You were diagnosing the time of day, not the pathology.
And the fasting, what's the physiology there?
A glucose load suppresses testosterone acutely. A sugary breakfast, pancakes, and syrup can drop your T levels by 20% for a few hours. So if they're on fasting, the number is garbage.
Right. So the patient is fasting. It's 8 a.m. We get the result. What is the magic number for the EAU?
12 nanomoles per liter.
12. And for our American listeners dealing in nanograms?
That's roughly 3.5 nanograms per milliliter, so 3.5. Here is the algorithm you need to know. If total T is above 12 nanomole, there is no hypogonadism. You stop.
Clear.
If total T is below 8 nanomole, it is highly likely hypogonadism.
And between 8 and 12, the gray zone.
This is the gray zone. Here you need to look closer. You check free testosterone or sex hormone binding globulin, the SHBG, to calculate the free T. That gives you a better picture.
But here is the critical exam trap. Do you treat based on one lab result? One single number?
Never. The guidelines are explicit. You must repeat the test on a separate occasion. Same conditions, morning, fasting. Only with 2 low values do you proceed. Bodies fluctuate, labs make errors. You don't commit someone to lifelong therapy on one data point.
Never, ever. Okay, we have 2 low values. We check LH-FSH. Let's say LH is low. We are in secondary territory. The brain isn't signaling. When do we need to scan the head? When do you order that MRI?
You don't scan everyone. That's low yield and expensive. You scan if there's a clinical suspicion of a pituitary macroadenoma. That means 1, elevated prolactin, and it has to be consistently elevated.
Okay.
2, symptoms of mass effect. So, new onset headaches, visual field cuts like bitemporal hemianopia.
And 3.
3, and this is a sneaky one, severe biochemistry.
Define severe. What's the number for that?
If total testosterone is incredibly low, the guidelines say below 6 nanomolar.
Below 6 is the trigger, even if prolactin is normal.
It's a weak recommendation, but yes. The thinking is that a T level that low suggests the axis has completely collapsed, and you need to rule out a non-functioning adenoma that's just sitting there compressing the stalk.
That's a great clinical pearl. Okay, let's move to treatment. We've diagnosed it. We want to give testosterone replacement therapy, or TRT, but TRT isn't a vitamin. It has risks. What are the absolute do not pass go contraindications?
There are 3 big ones you must recite for the exam.
Yeah.
Number 1, breast cancer in males. It's rare, but it's absolute.
Right.
Number 2, active or locally advanced prostate cancer.
And number 3.
Hematocrit.
The thick blood.
Polycythemia. If the hematocrit is greater than 54% at baseline, you cannot start T-chair. Testosterone stimulates erythropoietin. It drives red blood cell production. If they're already sludging at 54%, you're going to stroke them out.
54%. Burn that number into the brain. Is there a 4th one, a really important one?
There is, and it's the one that leads to the most lawsuits and the most confusion. Fertility.
This is so counterintuitive for patients, right? They think, I'm less of a man. I need man hormone to make me fertile.
It is the single biggest misconception. Exogenous testosterone is a contraceptive. It is effectively the pill for men.
Walk us through the mechanism. Why does adding T stop sperm production?
It's pure negative feedback.
Yeah.
The hypothalamus sees the high levels of testosterone in the blood, the stuff you injected or rubbed on, and it thinks, great, the testers are working overtime. I can take a break.
So it just shuts down.
It stops sending the GnRH pulse. Consequently, the pituitary stops sending FSH.
And FSH is the key.
Right. FSH, follicle-stimulating hormone, is the fuel for spermatogenesis. No FSH, no sperm. You induce azoospermia, 0 sperm, within months.
So if a 30-year-old guy comes in, low T, feels terrible, but he wants to have a baby in the next 2 years, TRT is malpractice.
Correct. If you give him T, you are chemically castrating him. It is absolutely the wrong thing to do.
So what do you offer him? He still has symptoms. You can't just send him away.
You can't. You have to stimulate his own production. You use off-label therapies, HCG, human chorionic gonadotropin, which mimics LH and directly stimulates the testes.
Okay.
Or you can use SERMs, selective estrogen receptor modulators like clomiphene citrate. This blocks the estrogen feedback loop in the brain and tricks the brain into driving the testes harder. The guidelines mention these as alternatives for fertility preservation, even if they are technically off-label.
That's a critical distinction. Okay. Let's assume our patient is 55, finished his family, and clears all the safety checks. We start him on T. How do we monitor him?
Safety first. You check his testosterone level, his hematocrit, and his PSA at 3 months, 6 months, and then annually.
What if the hematocrit starts creeping up? It hits 52, 53.
You watch it like a hawk. If it breaks 54%, you have to act. You stop therapy immediately, you can reduce the dose, or you can have the patient donate blood therapeutic phlebotomy. But you cannot let them run high. That is a major safety failure.
Clear. That's the hypogonadism module. Let's pivot to the vascular side of things. Section 2, erectile dysfunction.
A condition affecting, 50% of men over 50? But for the exam, you need to focus on the workup and the risk stratification.
We mentioned survival earlier. The guidelines call ED a biomarker. Unpack that for us.
It's the artery size hypothesis. It's pure geometry. The penile arteries are tiny, about 1 to 2 millimeters in diameter.
Very small.
The coronary arteries are 3 to 4 millimeters. The carotid arteries are 5 to 6 millimeters.
So if you have systemic atherosclerosis plaque building up everywhere, where will it clog first?
The smallest pipes, always. The penis is the canary in the coal mine for cardiovascular disease.
I've heard that phrase before.
And the numbers are stark. Erectile dysfunction typically presents 3 years before the onset of angina. It presents 5 years before a myocardial infarction. So when a man walks in with ED, you aren't looking at a penis problem. You are looking at a man who is about to have a heart attack in 3 to 5 years if you don't intervene.
That is a terrifyingly useful heuristic. So the workup isn't just, here's a script for Viagra.
No, we use the Princeton consensus, specifically the Princeton-Thiessen update from 2024. You have to risk stratify the patient before you prescribe anything, because sexual activity is exercise.
Right.
It's equivalent to walking 1 mile on the flat in 20 minutes or climbing 2 flights of stairs briskly. If they can't do that, can they safely have sex?
So who is high risk? Who gets sent straight to the cardiologist before they get a pill?
The unstable patients. Unstable angina. A recent MI specifically within the last 2 weeks. NYHA Class 4 heart failure, the really sick ones. Or uncontrolled arrhythmias.
And the logic is?
The logic is simple. If you give these guys a PDE5 inhibitor, which drops their blood pressure, and then they have the physical exertion of sex, the combination could be fatal. You need to stabilize the heart first. Always.
And the low-risk guys, the ones we can treat.
Asymptomatic. Fewer than 3 risk factors for heart disease. The guy who can climb the stairs without getting chest pain. You treat them.
What about the intermediate group? The guy with mild angina or multiple risk factors?
That's the stop sign. They need a functional stress test. You put them on a treadmill. If they can hit the MPs, the metabolic equivalents, required without ischemia, they become low risk. You can treat them. If not, they are high risk and need cardiology.
Let's talk about the drugs. PDE5 inhibitors. Sildenafil, tadalafil, vardenafil, avanafil. The guidelines say they all have similar efficacy. Is that true in practice?
Efficacy. For the most part, yes. They all work by blocking the breakdown of cGMP, keeping the smooth muscle relaxed. But the pharmacokinetics are really different, and that's what matters for the patient and for the exam vignette.
Okay, let's break that down. Sildenafil, Viagra, the OG.
Short half-life, about 4 hours. Critical point. It needs to be taken on an empty stomach. Big fatty meal will block its absorption, so it's a planned event drug.
Tadalafil, which is Cialis.
That's the weekend pill. Half-life is 17.5 hours. It stays in the system for up to 36 hours. And crucially, it's not affected by food. This is the drug of choice for spontaneity or for daily dosing.
Are there any absolute 100% contraindications for these drugs?
Nitrates.
Oh.
Absolutely. Nitroglycerin, isorbide mononitrate, also Popper's amyl nitrite used recreationally.
Why is that mix so dangerous?
It's synergy, a deadly synergy. Both nitrates and PDE5 inhibitors work by increasing nitric oxide and the cGMP pathways. If you combine them, you get massive, uncontrolled vasodilation. The blood pressure just bottoms out, and the patient dies of cardiovascular collapse. You have to ask about it every single time.
Okay, what if the pills don't work? We climb the treatment ladder.
Second line is intracavernous injections, ICI. The drug is alprostadil, which is prostaglandin E1. You teach the patient to inject a small needle directly into the side of the penis into the corpus cavernosum.
Patients must love that.
They're not thrilled at first, but it's highly effective. And here's why it works if the pills failed. Pills require an intact nerve signal to the penis. They just amplify the natural signal.
Yeah.
If the nerve is damaged, like after a radical prostatectomy, pills might not work at all. Injections bypass the nerve completely. They act directly on the smooth muscle to open it up.
And third line, the final stop.
The penoprosthesis, the implant. It's the end of the road, but it has the highest satisfaction rate of any ED treatment, over 90%.
Why is it so high?
Because it always works. It's mechanical. You squeeze the pump in the scrotum, fluid moves from the reservoir in the abdomen to the cylinders in the penis, and you are reliably erect. There's no waiting for a pill, no performance anxiety. It's just on demand.
Before we leave ED, I have to ask about the trendy stuff. You see it everywhere. Shockwave therapy, PRP, stem cells. Every clinic on Instagram is advertising these. What do the guidelines say?
The EAU is very, very conservative here. Low-intensity shockwave therapy, or LISWT, gets a weak recommendation.
Weak? Why?
Yes. The data is, it's mixed. There's a lot of heterogeneity in the studies. It seems to work best in patients with mild vasculogenic ED who respond to pills but want to get off them. It is not a magic wand for severe ED, despite the marketing.
And TRP, platelet-rich plasma.
Experimental. That's the word they use. The guidelines are explicit. Do not offer this outside of a clinical trial. There's almost no level 1 evidence that injecting plasma or stem cells regenerates erectile tissue in humans.
So for the exam?
If you answer PRP on your board exam as a standard treatment, you will likely fail that section. It's considered unproven.
Brutal, but necessary clarity. Let's move to section 3.
Yeah.
Issues with the finish line. Premature ejaculation, PE, and hematospermia.
PE is another one of those definition traps. It's a triad. You need all 3 legs of the stool to make the diagnosis.
Leg 1.
Time, specifically the intravaginal ejaculatory latency time, or IELT. For lifelong PE guys who've had it since the first time, it's usually less than 1 minute. For acquired PE developed later in life, it's usually less than 3 minutes.
Leg 2.
Control, the inability to delay ejaculation. It just happens.
And leg 3. This seems important.
It's the most important. Distress. Negative personal consequences. If the guy lasts 30 seconds but he and his partner are perfectly happy, it is not a medical disorder. You don't treat it.
Okay. So how do we treat it when it is a disorder?
Behavioral therapy is key, like the stop-start technique.
Right.
But pharmacologically, we have one on-label drug in Europe, duloxetine.
Which is an SSRI, right?
Yes, but a very short-acting one. You take it 1 to 3 hours before sex. It basically just exploits the most common side effect of SSRIs, delayed ejaculation, but without the long-term commitment.
Can we use normal SSRIs? Like paroxetine or sertraline?
Off-label, yes. And they are very effective. Daily SSRIs are probably more effective than on-demand duloxetine. But you have to warn the patient about the other side effects. Libido loss, weight gain, anorgasmia. It's a trade-off.
Let's talk about the scary symptom, blood in the semen, hematospermia. Patients freak out. They think it's cancer.
It almost never is, but you need a system to rule it out calmly and efficiently. The guideline splits the risk at age 40.
So the under 40 patient comes in.
Low risk. It's usually idiopathic. We never find a cause, or it's infectious like chlamydia or just some inflammation in the prostate.
Hmm.
If it's an isolated episode and the testes feel normal, the DRE is normal, you just reassure them. You don't need a massive, expensive workup.
The over 40 patient, though.
That's a different story. The risk of malignancy, specifically prostate cancer, starts to increase. So you need to do a DRE, a PSA, and likely a TRUS, a transrectal ultrasound, to look for prostate cysts, stones, or tumors.
Any other red flags?
Yes. If they have hematuria blood in their urine and hematospermia, that's a big red flag for either bladder or prostate cancer. You have to work that up thoroughly.
Section 4. Structural problems. Peyronie's disease. The curvature.
This is a fibrotic wound healing disorder. A plaque, which is basically scar tissue, forms in the tunica albuginea, the sheath of the erectile body. It acts like a tether, and so the penis bends when it's erect.
The management depends entirely on the phase. Active versus stable. How do you tell them apart for the exam?
The active phase is painful. The curve is evolving. It's actively getting worse. This phase lasts for about 12 months on average. The stable phase is when the pain is gone, and the curvature hasn't changed for at least 3 months.
And why does this distinction matter so much?
Because you never operate in the active phase. Never. If you operate while the disease is still active, the recurrence rate is massive. You're chasing a moving target. The plaque will just reform.
So what do you do in the active phase? Just tell them to wait and suffer.
Not entirely. It's conservative management, NSAIs for the pain. And the guidelines are now giving a stronger recommendation for traction therapy, mechanical penile traction devices.
Do those actually work?
The evidence is actually growing stronger here. If patients are compliant and use a traction device for 3 to 8 hours a day, which is a lot, I know, it can genuinely reduce curvature and, importantly, recover some of the length lost to the disease.
What about injections? Aclogenase, also known as Eoflex.
This is a key geographic distinction you have to know for your exam. In the U.S., it's FDA approved and widely used. In Europe, the EAU guidelines note that collagenase, CCH, was withdrawn from the European market.
So for a European exam.
It is not a standard option currently. You would not offer it.
Okay, that's crucial. So once they hit the stable phase, we can operate. We have a menu of 3 main surgeries. How do we choose?
It's a flow chart based on severity of the curve and their underlying erectile function. So scenario A curve is less than 60 degrees. They have good erections and a reasonably long penis.
Action.
Location. You stitch the long side of the penis to shorten it and straighten the curve. It's simple, it's low risk of causing new ED, but it always shortens the penis a little bit more.
Scenario B, severe curve, over 60 degrees, or maybe an hourglass deformity, or a short penis to begin with.
Right, you can't afford to shorten it further, you have to lengthen the short side.
Yeah.
So the action is incision and grafting. You cut the plaque open and you sew in a patch. It could be a vein graft, pericardium, collagen fleece.
What are the pros and cons there?
Pro, it preserves or even gains length. Con, it has a high risk of worsening their ED, maybe 20 to 30%, due to sensory loss or venous leak.
And the final scenario, scenario C. They have the curve, but they also have bad ED that pills don't fix.
That's the one and done operation. You place a penile prosthesis, you put in the implant, inflate it, and then you manually model, you basically crack the plaque over the rigid cylinders. You fix the curve and the erection in one go.
Let's move to section 5. The one that makes every urology resident sweat at 3 a.m. priapism.
An erection lasting more than 4 hours without stimulation. It is a compartment syndrome of the penis, and you have to treat it like one.
The critical fork in the road is ischemic versus non-ischemic. Getting this wrong is a disaster.
It is. Ischemic or low flow is the emergency. Blood is trapped, it isn't leaving. The cavernosa become hypoxic and acidotic. The muscle will die and turn to fibrosis, causing permanent ED.
And non-ischemic.
The non-ischemic or high flow
Yeah.
is usually from trauma. The guy fell on the crossbar of his bike, got a perineal injury. He has an arterial fistula pumping oxygenated blood in. It is not an emergency.
How do you differentiate them at the bedside quickly?
Clinical exam first. Ischemic is fully rigid and painful. Very painful. The head is socked because the spongiosum isn't involved. Non-ischemic is usually semi-erect, kind of rubbery and painless.
But the definitive test is the blood gas. You stick a needle in the penis and draw blood. What are we looking for?
The color tells you the answer before the lab does. Ischemic blood is black. It looks like motor oil. Non-ischemic blood is bright red, like arterial blood.
And the numbers, if the examiner asks for the numbers?
Ischemic is acidotic pH less than 7.25. It's hypoxic APO2 less than 30 mmHg. And it's hypercaptic high CO2. It's dead, stagnant blood.
Non-ischemic looks like normal arterial blood, normal pH, high O2.
Okay, it's black blood. It's ischemic. It's been 5 hours. What is the step-by-step drill you need to recite?
Step 1. Decompression. Stick a large gauge needle, like a 19 gauge, into the corpora and aspirate. Drain the old blood until you start to see fresh red blood.
Step 2.
Irrigation with saline, just to wash out the sludge. Step 3. Intracavernosal injection of a sympathomimetic. The drug of choice is phenylephrine. Why phenylephrine specifically?
It's a pure alpha-1 agonist. It causes smooth muscle contraction without the beta effects that would mess with the heart rate and blood pressure too much. You want the cavernous, smooth muscle to squeeze down and push the blood out. You inject it every 3 to 5 minutes while monitoring their BP and pulse.
And if that fails after an hour, the penis is still rigid.
Then you go to the OR for a shunt. You start with a distal shunt first. The Winter or Ebehoij procedures. You create a window between the stuck corpus cavernosum and the glans, which is part of the corpus spongiosum, to let the blood drain out the normal venous system.
Okay, last major section. We're almost there. Section 6. Male infertility. This is becoming huge. Sperm counts are dropping globally.
They are, and the exam expects you to know the numbers cold. The WHO manual, 6th edition from 2021. These are the reference limits. They represent the lower 5th percentile of fertile men.
Let's verify the memory bank. You're the expert. Volume.
1.4 ml.
Concentration.
16 million per ml.
Total count.
39 million per ejaculate.
Motility. This one's tricky.
30% progressive motility. That's the ones that are swimming straight, actually going somewhere.
In morphology?
4% normal forms. This shocks people. It means you can have 96% abnormal-looking sperm and still be considered to have a normal analysis.
Let's talk about the nightmare scenario for a patient. Azoospermia, 0 sperm. How do we classify this?
Obstructive, or OA, versus not obstructive, NOA. OA means the factory works, but the pipes are blocked. A past vasectomy, or being a CF carrier with absent testosterone. NOA means the factory itself has shut down.
How do we tell them apart without cutting the guy open?
FSH and testis volume. If the FSH is normal and the testis volume is normal, it's very likely an obstruction. The brain thinks everything is fine. But if the FSH is high and the testis volume is small, it's non-obstructive. The brain is screaming at the failing tests to work harder.
We have to talk genetics. This is extremely high yield for the boards. When do you order a karyotype?
If the sperm concentration is less than 5 million per ml, that's severe oligospermia, or if they have azoospermia. You are looking for Klinefelter, 47,000XXY, or chromosomal translocations.
And the Y chromosome microdeletion?
Same indications.
Yeah.
Less than 5 million or azoospermia. You are looking for deletions in the AZF azoospermia factor regions on the Y chromosome. This is absolutely critical for counseling because it determines the prognosis.
Break down the AZF zones for us, A, B, and C.
This is a must-know. If they have a complete deletion of AZF or AZFB, the prognosis for finding sperm with surgery is virtually 0. You do not offer them TEES, testicular sperm extraction. You advise adoption or donor sperm.
But AZFC is different.
Totally different. If they have a deletion of AZFC, there's about a 50% chance you can find sperm with micro-TEES. But, and this is the catch you had to mention, if you use that sperm to make a baby boy, he will inherit the deletion. He will also be infertile. You must counsel the couple on this vertical transmission of infertility.
One final structural issue in infertility, the varicocele, the bag of worms, dilated veins in the scrotum. We see varicocele in fertile men all the time. When do we actually fix it?
The EAU has very strict criteria to stop us from overtreating. You only repair varicocele if it meets all the criteria.
What?
1, it has to be palpable, a clinical varicocele. An ultrasound-only subclinical one doesn't count.
Okay.
2, the semen analysis must be abnormal. 3, the couple has documented infertility usually for more than 2 years. And 4, the female partner is healthy with good ovarian reserve.
So if the guy has a huge varicocele but his sperm count is 100 million.
Do not touch it. There is absolutely no evidence that fixing it improves pregnancy rates if the sperm is already normal. You'd be operating for no reason.
We have covered a marathon of ground from the circadian rhythm of testosterone to the acidic blood of priapism. If you had to leave our exhausted resident listener with one overarching thought from these 2025 guidelines, what is it?
It's the shift. The shift from thinking about these issues as quality of life problems to understanding them as biomarkers of health. When you treat a man for ED, you are preventing a heart attack. When you diagnose a man with infertility, you are screening him for testicular cancer and future metabolic disease. Urologists are the gatekeepers of men's health. The guidelines are designed to make sure we don't just fix the symptom, but we save the patient.
High stakes indeed. Listeners, take a breath. Go get some sleep. The transcript is in the show notes for your review. You're going to crush the exam. Thanks for listening to The Deep Dive.
Good luck. You've got this.